Welcome back to the channel. Today we're diving into a craniotomy procedure, including some anatomy, procedure steps, and anticipation tips. First, I'd like to introduce myself. I'm a CST and a surgical tech instructor. I also just completed a book called The Surgical Technologist Guide to Procedure Steps and Anticipation Tips. You can find that on Amazon. I'll put the link in the description of the video below. This book includes 207 procedures with steps, instrument suggestions, and suggested Mayo stand setups. In addition, I developed surgicaltechreview.com to help surgical tech students throughout their program and exam. I'll put the link to that site in the description. I also added a bundle deal for you with the book and the website. If you go to the website and you go to checkout for premium, you'll see the bundle deal. Now let's get started with today's video on a craniotomy. When planning a craniotomy, the anatomy of the brain is critical. The brain is divided into lobes, and the location of the pathology determines where the surgeon will operate. Major blood vessels and functional areas must be carefully avoided to prevent neurologic damage. A craniotomy is chosen when direct visualization of the brain is required. It's commonly performed to remove space-occupying lesions or when rapid decompression is needed, such as in cases of bleeding or increased intracranial pressure. One of the most common reasons for a craniotomy is the removal or biopsy of brain tumors. These may be primary tumors or metastatic lesions, and the goal is to remove as much tumor as safely possible. Craniotomies are also performed to treat intracranial bleeding, including epidural, subdural, and intracerebral hemorrhages. These cases are often emergent because bleeding can rapidly increase intracranial pressure. In severe head trauma, a craniotomy may be necessary to relieve increased intracranial pressure caused by swelling, depressed skull fractures, or traumatic brain injury. Craniotomy cases require multiple specialized instrument sets. These include neurosurgery, craniotomy, cranial bone, dural, and microsurgery sets, along with a drill system, Burrs, and a craniotome. The surgical technologist plays a critical role in a craniotomy. Craniotomies are typically performed under general anesthesia with endotracheal intubation. In select cases, such as those involving speech or motor mapping, an awake craniotomy may be performed using local anesthesia and sedation. The patient's head is secured using Mayfield head pins. This provides rigid fixation and prevents any movement during drilling, which is essential for safety and accuracy. A curvilinear incision is most commonly used. This type of incision preserves blood supply to the scalp, provides adequate exposure, and allows for better cosmetic healing. The Mayo stand is set up with scalp and exposure instruments. Because the scalp is highly vascular, instruments for rapid bleeding control, such as Raney clips and hemostats, must be immediately available. Step 1. Positioning and verification. The patient is positioned based on the location of the pathology and the head is secured. A timeout is performed to confirm the correct patient, procedure, site, and imaging. Step 2. Scalpel preparation and draping. The scalpel is prepped widely and sterile drapes are applied. Care is taken to maintain access for navigation equipment and the surgical microscope. Step 3. Mark incision and craniotomy site. The surgeon marks the incision and craniotomy site using imaging or navigation to ensure accurate placement before the incision is made. Step 4. Scalp incision. The scalp incision is made using a scalpel. Because the scalp is highly vascular, immediate bleeding control is required using clamps or Raney clips. Step 5. Dissection through galeia and periosteum. Dissection continues using scissors and hemostats. Bleeding is controlled early to maintain clear visualization. Instruments include Metzenbaum scissors, 2 mosquito hemostats, Addison forceps. Clamp cut rhythm is common. Control bleeding early to maintain visualization. Step 6. Reflect the scalp flap. The scalp flap is reflected to expose the skull. Retraction is maintained while monitoring the flap edges for bleeding. Instruments may include handheld retractor passed from the back table when requested. Anticipation, flap edges may ooze. Anticipate rapid clamp placement without crowding. Step 7. Burr hole placement. A drill with a perforator is used to create burr holes in the skull. The surgeon confirms burr hole locations and avoids underlying vascular structures. Instruments include the drill and perforator passed from the back table. Anticipation. Confirm burr hole locations and drill bit type before passing. Step 8. Create a bone flap. A craniotome is used to connect the burr holes and create the bone flap. Irrigation is used to control heat and bone dust during this step. Instruments include craniotomy. Anticipation, maintain bone flap orientation. Be ready to manage bone dust control. Step 9. Elevate and preserve the bone flap. The bone flap is carefully elevated and preserved in a sterile manner for later replacement. In cases of severe swelling, the bone may be left off. Step 10. Open the dura. The dura is opened carefully using dural scissors and forceps. Cottonoids are placed to protect the brain, and dural tack-up sutures may be used. Step 11. Intracranial procedure. The intracranial portion of the procedure is then performed. This may include tumor removal, clot evacuation, or repair of damaged structures. Step 12. Achieve hemostasis and irrigation. Once the intracranial work is complete, the hemostasis is achieved and the surgical field is irrigated in preparation for closure. Step 13. Close the dura. The dura is closed using sutures or dural substitute. A watertight closure is preferred to reduce the risk of cerebrospinal fluid leaks. Step 14. Replace the bone flap. The bone flap is replaced and secured with plates and screws. All cranial hardware is carefully counted and confirmed. Step 15. Layered scalp closure. The scalp is closed in layers. A drain may be placed, and closure proceeds quickly at this stage. Step 16. Sterile head dressing. A sterile head dressing is applied to protect the incision. Care is taken to avoid excessive compression, especially if a drain is present. That includes all of our steps for craniotomy. Again, if you want more information or to do a little more review, check out surgicaltechreview.com. If you're looking for more procedures and more steps and anticipation tips, check out our Amazon link in the description for the Surgical Technologist Guide to Procedure Steps and Anticipation Tips. And always, like and subscribe.